Welcome to the Spark Live webinar series, one component of our Spark Knowledge Mobilization program. Spark is Children's Healthcare Canada's shared platform for advocacy, research, and knowledge. Spark Live is where we gather each week to curate, convene, and showcase excellence and innovation from across the child and youth healthcare community. Our goal is to spark conversation, ideas, and action. Children's Healthcare Canada would like to thank our funding partners for their ongoing contributions that support all of our programs and activities, including this Spark Live bi-weekly webinar series. There are two options to join in on the live conversation. Questions and comments for our panel or presenters can be typed into the question box, or comments that you want to share with the audience can be typed into the chat box visible to all of our attendees. For those of you on Twitter, tag @ChildHealthCan on any webinar-related tweets or use the hashtag SparkLive. And to keep up to date on all of Children's Healthcare Canada's webinars and other activities, be sure to sign up for our weekly Spark News e-bulletin by visiting our website at childhealthcan.ca. Hello everyone, and welcome to another edition of Children's Healthcare Canada's Spark Live webinar series. The Spark theme for February is Right-Sizing Health Systems, Community-Based Care for Children and Youth. I'm Paula Robeson, your host for the next hour. I'll begin by acknowledging that Children's Healthcare Canada operates on the traditional and unceded territory of the Algonquin Anishinaabe peoples. We recognize and deeply appreciate their historic connection to Ottawa. Today, Ottawa is home to Indigenous peoples from all across Turtle Island. Children's Healthcare Canada is committed to working towards forging new and deepening existing relationships that include First Nations, Inuit, and Métis peoples, and is grateful for the opportunity to share this land as we work to measurably improve children's health outcomes from coast to coast to coast. We're delighted to speak with Katie Burney and her colleagues today to bring you Youth in Pain, Solutions for Effective, Safe, and Equitable Medical Use of Opioids for Pain in Youth. This webinar is provided by Children's Healthcare Canada in collaboration with Solutions for Kids in Pain, or SKIP. It's now my pleasure to pass the mic to Katie to introduce today's topics and speakers. As Katie is introducing the speakers, we invite you to answer a few quick poll questions for us. Please note, you'll have to answer all of the questions to submit your response.
Thank you so much, Paula. It's a pleasure to be here. And just before we get started, just also want to give a huge thank you to Children's Healthcare Canada for being a co-leading organization with SKIP over the last 5 years, and just always appreciate this partnership, including the opportunity today. And also Children's Healthcare Canada's partnership on this project that we've been leading, funded through Health Canada's Substance Use and Addictions program for the last almost 18 months now. So I'm a clinical psychologist and an assistant professor at the University of Calgary, and I'm also associate scientific director for SKIP. And just I'll introduce the amazing colleagues and collaborators on the call with us. The first after I speak is going to be Dr. Melissa Pielek, and Dr. Pielek is a licensed psychologist and assistant professor at Brown University. She has unique cross-cutting expertise in the etiology, co-occurrence, and treatment of both pain and substance use behaviors in adolescents and young adults, making her perfect to partner with us and as a member of our national advisory group for this project. And Dr. Pielek's National Institutes of Health-funded program of research focuses on understanding relations between pain and substance use behaviors in youth, using innovative research methodologies such as ecological momentary assessment and qualitative work, patient-centered development and evaluation of interventions that co-address pain and substance use, and really importantly, addressing systems-level barriers to family involvement in youth opioid use disorder treatment. So really excited to hear from Dr. Pielek today. After that, we'll hear from Sabrina Canella, and a huge gratitude to Sabrina for joining us this morning. So Sabrina is a firm believer in Mahatma Gandhi's words, "Be the change you want to see in the world," and strives to embody, implement, and encourage others to do the same through her advocacy to a number of causes. Sabrina grew up in Woodbridge, Ontario as a typical happy, healthy little girl that thrived as a competitive dancer until she began to fall ill with a progressive autoimmune disease that has absolved her of the ability to eat orally, sustain nutrition, and years of chronic pain. Though her life's path has drastically changed to accommodate her illnesses, it is not consumed by them. And her survival and quality of life today are due to the tireless efforts of the staff at Sickle that provided her with the tools to manage her conditions and the power of advocacy. So with intentions of one day being a nurse at Sickle, Sabrina is grateful for the opportunities that allow her voice to be heard as a patient partner with Skip. We're also honored to, Sabrina. So thank you for sharing your expertise and lived experience with us and your advocacy. And Sabrina is honored to have a hand in advocating for pain management for other pediatric patients, and is humbled to be able to be a bridge between healthcare providers and patients and their families who have or will walk a similar path. So really looking forward to hearing from Sabrina. And then to close us out, before we are excited to hear all of your questions and have some great discussion, is Dr. Marie-Joëlle Doré-Bergeron. And Marie-Joëlle is a pediatrician at CHU Saint-Justine in Montréal and an assistant professor in the Department of Pediatrics at the Université de Montréal. She is the director of the Interdisciplinary Chronic Pain Clinic, and she's interested in the improvement of procedural pain management for children being treated in hospital and increasing the availability of resources for children with chronic pain, paying special attention to resources available for French-speaking Canadians. She also has a particular interest in increasing the recognition of pain in children with severe neurological disabilities in the medical community. And Dr. Doré-Bergeron is a hub co-lead for the Francophone hub for SCIP at CHU Saint-Justine, and is also a member of the National Advisory Group for this project. And you'll see today some of the incredible work that they have led to develop some new resources that touch on this important issue of opioids and pain. All right. So I'll just acknowledge where I am today. I know you're all in different places across the country, and if you're interested, I encourage you to put where you are or your own land acknowledgement in the chat. And I'm here today in Treaty 7 region in Southern Alberta. Just briefly, SCIP's in its fifth year now, so hopefully most of you have heard about SCIP, but we're a national knowledge mobilization network, which means we don't do research, we don't do specific training or deliver healthcare, but we really bridge that gap between the evidence-based solutions that we know from research and engagement work to improve children's pain. We're actually reaching those who can use it every day. And our mission is to do that through coordination and collaboration with others. Why does this matter? Pain is pervasive, so it impacts 1 in 5 children before they reach adulthood, and pain is very common for hospitalized children, despite all of this incredible research knowledge that we have. It has short and long-term consequences. You heard a little bit about this already, even in just as I introduced Sabrina, but certainly poor pain management leads to all sorts of different consequences, including increased pain sensitivity, neurodevelopmental and socio-emotional challenges, healthcare avoidance, vaccine hesitancy, mental illness, opioid use, which we'll talk about today. And I think increasing research showing that many of these impacts last into adulthood, even for those with whom pain resolves. It has huge direct and indirect costs, both to individuals and families, but also to society in terms of economic burden, well captured in the Canadian Pain Task Force's reports. And I think really importantly, it's a human right. So, and I think especially as we're looking in today's world and conversations, it's also reminding ourselves it's also a human right for children and their families. And SCIP really focuses on prioritizing that children and youth and their families are part of these important national conversations that we're having. SCIP is engaged in all sorts of different activities. We've all sorts of different things, videos, tools, resources, many, many things that you'll even see a few showcased today. But some really key initiatives we've been leading that really respond to Health Canada's action plan for pain in Canada include publishing with the Health Standards Organization, the world's first pediatric pain management standard last year. And then also this project we're talking about today, focused on opioids for acute and chronic pain. All of this work shares a common objective to improve equity, quality, and consistency of pediatric pain management across Canada. So here we are talking about youth in pain and this project for effective opioid use. This work initiated from a scoping meeting and engagement that took place in February 2020 with 29 folks from across the country who represented people with lived experience, multidisciplinary health professionals, and also other organizational partners interested in this space. Skip had the privilege of partnering with the Canadian Foundation for Healthcare Improvement, now Healthcare Excellence Canada, and it culminated in an executive summary and report. And this discussion, this one-day discussion and meeting really identified the need for more clarity, guidance, and support that was specifically focused on opioid use for pain in children in the medical context. And this is where an action plan was co-developed. We had the opportunity a year or so later to actually apply to funding through Health Canada's Substance Use and Addiction Program to carry out this co-developed action plan, which is phenomenal. We came together, we said these actions are needed, and then we had the opportunity to make them happen. And so we're excited to share with you today some of the results of that. Our objectives were to assemble a national advisory group, really working across SKIP's network and with partners to create tools and resources that support youth, families, health professionals, and decision makers in the effective, safe, and equitable use of opioids for pain in children, and to raise awareness through a public awareness campaign that we ran during Pain Awareness Week in November of last year, and to promote policy and system level supports. I'm thrilled to say that that public awareness campaign in 1 week through other media engagement reached at least 9 million people in Canada. So I'm not going to go through all of these, but just wanted to give you a snapshot sense of the diversity and number of knowledge mobilization tools that we've been developing across the network. And we recently have been awarded additional funding that will be helping us to deliver more things like this webinar before the end of March. So at the end of the whole project, I think our tally will be 31 different tools or activities that have supported, in both English and in French, that have supported mobilizing evidence-based solutions for opioid use for pain in children. So encourage you to check out the SKIP website. There's a youth and pain subsite there. You can learn more about the project. All the resources as they're being developed are uploaded there. And then there's a QR code there where we're always looking for feedback on the tools, and certainly welcome hearing from you as well. So with that, I'm going to turn it to Melissa so we can talk more about medical use of opioids for pain during the overdose pandemic.
Awesome. Thank you so much, Katie. I'm so excited to be here and honored to be part of this panel of such brilliant people doing such brilliant and important work. I am zooming in today from down in Providence, Rhode Island, on the ancestral and stolen lands of the Narragansett Indian tribe. Next slide. So I'm excited to kind of kick off our conversation with some acknowledgement around the complexity of this topic and the complexity of what this project sought to accomplish and sought to what we're sort of juggling as we're trying to do this work. As Katie had mentioned, in my clinical and research and advocacy work, I sort of straddle two worlds between pediatric pain and youth substance use. And if there's one thing I have learned in this journey so far is that too many youth suffer from both pain and substance use that is too often overlooked, undertreated, and highly stigmatized. And both conditions are largely preventable and treatable, and there's such gaps in making that happen. Next slide. And as I mentioned, kind of sitting in this world, feeling like there's sometimes a bit of a disconnect in the conversations and the narratives happening in regards to youth opioid and substance use and advocating for pediatric pain. There are such strong and valid narratives on both sides of this conversation. I work with youth who are so impacted by persistent pain conditions, share experiences of being dismissed by healthcare providers, and who really just have also fears around different medications, opioid treatment options, given the headlines in the media around the opioid and overdose epidemic. And then on the other side of the conversation, in some of my advocacy work on family involvement in youth opioid use disorder treatment, I know far too many caregivers and family members who have lost children and loved ones to opioid-related poisoning and overdose. And both of these narratives are so real and so valid and so true and hard to hold at the same time when we're advocating for children's health care in both spaces. Next slide. So in my few minutes of talking with you today, I am encouraging us to think about holding two truths in this conversation and in this work that we do as healthcare providers and researchers. Next slide. First, that opioids can be an important and essential pain management tool for youth, and opioids can cause harm. And I want to spend a couple minutes kind of unpacking this and acknowledging what's underneath both of these, what I'm calling truths. Next slide. So when we're talking about opioids, the reality that opioids can cause harm, some things that this does not mean. This does not mean that opioids are not safe. In fact, opioids can be used safely, can be used effectively, and are essential for pain management for some acute and chronic pain conditions, for promoting functioning, healing, and recovery. Next slide. And as Katie emphasized in her introduction, and I think all of us share this narrative, all youth deserve equitable pain management, and this may or may not include opioids. Additionally, when we're considering potential harm, negative consequences from opioids, this doesn't mean that a child will become addicted to prescription opioids if they take them. And it also doesn't mean that youth who take prescription opioids have or will have a substance use disorder. Next slide. Fortunately, in fact, rates of opioid use disorder among youth and young adults are fairly low. In adolescents in particular, it's about 1% to 2% of youth. But I'll talk about this more a little bit later about implications related to that. And I also do want to acknowledge on the flip side of this that youth who are prescribed opioids report feeling stigmatized, report challenges in filling their prescriptions, and with getting the treatment that they are prescribed and need. And then lastly, and importantly, when we're considering potential harm from opioids, this doesn't mean that it's better or safer to tough it out than to take prescription opioids when they are clinically indicated. In fact, this beautiful graphic from Skip, undertreated and untreated pain in youth has lasting short and long-term potential consequences. And another thing to consider is that among youth that use opioids in a way other than prescribed or use engage in non-medical opioid use, pain relief is a commonly identified motive. So consideration of pain management in the context of the overdose crisis that we're facing is absolutely essential. Moving to the second kind of truth that I put on the table here, that opioids can be an important pain management tool for youth. What this does not mean, this doesn't mean that opioids are the only pain management tool for youth. In fact, one of the things I love about the tools that have been created from this project is shining a light that this is part of one tool, and also using opioids, using medication, pharmacological treatments, along with psychosocial and physical pain management strategies is essential. This also doesn't mean, though, that there's no risk associated with taking opioids as prescribed. And so that's so tricky with our language that we want to say it's safe, but we also want to acknowledge that there are potential risks and that we want to try and mitigate those risks. And so thinking about adverse events and side effects of like respiratory depression, things like that. And then, of course, overdose and poisoning, both for the individual prescribed opioids and considering those around them within their household and within their community. But many of these risks can be mitigated with proper family education, dosing, and follow-up support. A lot of those topics are addressed within the tools from this project. And also, this does not mean that overdose or poisoning won't happen or doesn't happen with prescription opioids. The reality more recently in the United States, overdose rates among youth are at their highest level. And I also am familiar with headlines within Canada too, that adolescents in particular, rates of overdose are very, very high and escalating. And most opioid related deaths are involved with tied to non-prescribed opioids. And we also can acknowledge that decreases in opioid prescribing haven't equated to decreases in overdose. And so there's a complexity here, but there is still reported use of leftover prescription opioids for recreational purposes. And just acknowledging the impact of drug overdoses within Canada, particularly for youth, that they're more, some data suggests, more likely to die from an overdose than in a auto vehicle accident. So bringing this kind of all together, how and why does this matter to youth prescribed opioids as part of medical care when there's both these narratives and all of this happening all at once in the context of an acutely or chronic pain kind of clinical encounter? So as I mentioned before, about 2% of adolescents report using opioids in a way differently than prescribed. This is sometimes referred to as opioid misuse behavior. And while this is fortunately pretty low, next slide, the impact of opioid use disorder on youth is really severe. And we also want to acknowledge that leftover prescriptions remain a primary source for using opioids differently than prescribed. And again, just a bit more numbers here, about 0.1% of youth report fentanyl use, illicit fentanyl use. So what I think is important to highlight here, though, is that when we're talking about substance use in the context of youth and adolescence, most consequences of youth substance use are not necessarily related to addiction or having a substance use opioid use disorder, but the fact that all substance use comes with risk, and that adolescents are more susceptible to risk-related injuries associated with substance use, which reminds us just about taking extra precautions to mitigate those risks and to ask for family support in managing prescribed opioids when they're indicated. And so kind of bringing things all together here, just underscoring the importance that when we're advocating for safe and effective opioid use with youth, that also involves addressing these intersecting crises with opioid use disorder, mental health, and the impact of those on young people. And those of us who are working in this space clinically, conducting research in this space, we have a responsibility to prescribe and to oversee use of prescription opioids in a way that really tries to maximize the benefit for managing pain, improving functioning, healing, but also minimizing potential for harm, and providing families with accurate information about these topics. I also want to highlight too that we have an important role in combating the stigma, both stigma that youth feel with pain conditions, and also that youth feel who are using substances and using drugs. We can model this in our clinical and research work by using patient-centered language. This sounds kind of simple, but providing compassionate care, taking time to listen, understand the experiences of where our patients are coming from, maintaining an open, curious attitude. If a youth shares with you about using substances in the context of needing pain management, being open, understanding where they're coming from, offering them support, and being responsive to that. Again, providing accurate, accessible information to youth and families, and also just modeling, holding these two truths, acknowledging these two truths, and keeping them in our mind. So just to kind of wrap things up, again, bringing it back to these 2 points that opioids can and are an important pain management tool for youth, and they can cause harm. And what I want to emphasize is we can maximize benefits, we can minimize harm, and we can do so in a way that promotes safe and equitable pain treatment for youth.
Thanks so much, Melissa. I think really important setting the stage, and I think I'm really talking about the stigma aspects. Both you mentioned stigma that can be related to pain, but also stigma that can come about from substance use and opioid use as well. Sabrina, I'm going to give you the floor just to share a little bit from your perspective and your own lived experience.
Hi, thank you so much for having me. It's an absolute honor to be able to speak with you guys and on this incredible panel. I'm completely humbled and honored to all of you for taking the time to even listen to my story and take the time to change perspectives in the way that things are going for kids. So I guess I'll start with my story. So I grew up normal, healthy little girl, competitive dancer until I was 12. And that's when when my condition first started to manifest as what came across as classic appendicitis. For a good 6 months, I was going back and forth from hospitals, going in pain with classic symptoms of appendicitis. But they were never able to find my appendix on an ultrasound or blood work. So it always was a wish-wash. I would flare, I would go in, I would come back. And I remember the first time that I went to when I was in the emergency room and they asked me if I wanted something stronger for pain, and they had offered me morphine. And I remember instantly thinking in my head, like, Grey's Anatomy, whoa, that was a big thing for my little mind to process, especially being, we've done such a great job at emphasizing the risks, especially in schools, in education and all of that. We've done such a great job emphasizing the risks that sort of overtook my mind at that age. So I encountered a lot of course, doubt from a lot of clinicians, which is totally fair. But eventually I came to Sick Kids and they took my appendix out because they were like, you don't need it. This seems to be what the problem is. Let's just see. And it actually came back that it was infected and my body was purging the infection itself. And it was filled with carcinoid tumors that were backing into my intestine as well. And this was something that I definitely didn't see it. I didn't foresee it coming, and that changed the course of action drastically. Surgery went well, and afterwards I was hopeful that I was going to be able to return to my normal life, but it was another blow when I found out that, when I started only 4 months later to have pain in my gallbladder and my liver, and went through the same thing again. This time I went into it knowing what I would face with when I would go in. And at this point, I had some sort of advocacy or some sort of understanding of what worked for me and what I needed to be able to attend school, attend dance, and maintain normalcy in those times. This is where things got a little bit more serious because I started to get a lot more pain while I was eating. My gallbladder was taken out again after trial and error, and again found with carcinoid tumors. And from there, my digestive system pretty much shut down. From the lack of bile, my stomach stopped moving, my intestines stopped moving, they stopped absorbing, and pretty much I was headed towards intestinal failure. And in this whole experience, this is over the course of me being 14, 15, 16, I'm still being mindful of what I'm being told and what I know. But also at this point, I'm very firm in realizing that I'm going to need some help to get myself across, to get myself from day to day in order to be able to do things. And for my parents, that was, I followed their lead. That was difficult, giving their child substances that automatically, the first thing that's said afterwards is the risk of it. And like I said, we've been doing great with, talking about all of the things that have gone, the things like the potential risks of it. So I adapted along with my parents pretty much the attitude of pain medication, specifically opioids, were a last resort. And I'm still trying to unlearn that in my head. I find myself a lot that I'll wait a long time before I go and take my pain medication. And it doesn't end up working. It just ends up being a game of me chasing my pain, not being able to do it. And it was very conflicting. And I met a lot of fair enough, challenges and insight into how I could maintain and live a life with what was becoming chronic pain, and being on opiates and figuring out what that looked like. And a lot of the time that immediately was pretty much one of the things that we wanted to discount from my care when we were looking at my pain. That was the first thing that we wanted to settle with. It became, again, clear that I needed, even just to be able to eat, to be able to even withstand feeding tubes or tube feeds, I needed the pain medication. And we hit a wall with, well, it could be hindering, well, it could be causing a lot more of your problems. Definitely isn't helping it. But without it, it definitely wasn't helping me either. Fast forward to when I'm in the adult world, I'm still even more so meeting a lot of resistance with doctors. I go in there with my own apprehensions, and my pain is always when they ask you to rate it, which is always a difficult question. I found myself kind of underplaying it because I didn't want to come across as all of the risks, and felt that that was the process I needed to follow because I didn't want that immediately to be thought of me. I didn't want not to be taken seriously because previously that had happened for a very long time. So I went in guarded until I dislocated my shoulder and needed surgery to restabilize it. And from there, I developed a condition called complex regional pain syndrome, or reflex sympathetic dystrophy. It's also known as the suicide disease. It has, on the McGill pain scale, it's one of the highest rated pain things. And even now saying that, I'm feeling that I have to not justify it, but just to say that it's an incredibly painful condition. And this is where I definitely met my realization of the only way that I'm going to be able to function is to control this pain, because this is what's holding me back. We're meeting my nutritional needs, we're meeting everything else. It was my pain at that point that was holding me back. And putting opioids back into my care was pretty much, at a certain point, it was essential, and there wasn't really another question of it because I couldn't even have clothing on my arm. The cold air would hit it. It was incredibly difficult, and it still is, to still be on the opioids. But I got the understanding from there that it's not a bad thing to use opioids, and it's not just a one part thing. Pain management is a multi-modular world, and in order to take advantage of the things like physical therapy and mindfulness and all of those things that I had written off previously because I was in so much pain that I couldn't focus on what I was being told to do. And I couldn't sit in my mindful mind. I couldn't do things with physical therapy. And that hindered a lot of my progress. And eventually we realized that it was a part of my care plan and it was okay. And it's something that I had to become very confident in, and maintain and assert when I can. But it became abundantly clear that it's important that this is a multi-modular approach. It's not looked at just through one lens. Of course, short-term is great, but if it's needed long-term, kids shouldn't be made to feel guilty or bad or like they have to defend themselves when they're asking for pain control, which, yeah, it's the basic human right. And I'm just working with Skip was an absolute honor to be able to destigmatize and reinforce, the benefits of it and how we can safely use it. And to reiterate to parents too that, they don't, when they hear the name or they know the class, they don't immediately have to go into panic mode as it's something we should avoid, because it definitely can be something that's very, very beneficial. Of course, used in the right context. And today I still require opioids to be able to manage my pain, to be able to function and, eventually get to school. And that's okay. But there are so many other portions of my life that I've incorporated, and even being able to speak with you guys and being involved in this project really helped me take back my power and take back my control. And when my pain was controlled and I was able to see all the benefits, it all made sense to me. And it's hard for the outside to see it. It's very hard from an outside perspective, especially as a parent or, a prescriber that's giving this high-class medication. It's very difficult. But if anything from this, I ask you just to, pain is it's an individual experience, very much so. What works for one person won't work for another. And that's okay. It's okay to explore those things. And it's okay sometimes to go back and look at that and go with what works. Just focusing on the safe route of administering, disposing of it, working with your healthcare team and advocating. And I just encourage you to listen to your patients or your children as much as you can and with an open mind, because you can't fathom what another person's feeling, especially your child. And you shouldn't have to go through your childhood in pain because of a stigma, because that holds back so much potential and it holds back so much of your personality and your life. And really, I'm able to thrive because I do have access to opioids and to these medications. Again, not being the only thing, but if it wasn't in the picture, I notice it when it's not in the picture, and I still to this day argue, go back and forth with it in my head. But I'm grateful that we can have this conversation, and I encourage you to continue to explore it and just approach with an open mind.
Thank you so much, Sabrina.
Thank you.
So many nuggets of gold in there that I think were really well said and really capture the complexity of what it's like, what it was like for you as a child. Now, what that's like for you as an adult, and how it intersects so much with family members, with friends, with health professionals, with transitions in care, with stigma, with the invisibility of pain, with, all of those things as well. So you've just said it all beautifully. So thank you very much for sharing.
Thank you.
Really just echo, how much, how important we really wanted this project to be, because I think some of the things you've brought forward, we felt were really missing in the broader conversations about chronic pain and the broader conversations about opioid use, whether specifically with the adult populations, or how they were being discussed more as it related to youth. So just thank you for sharing your experience. And I think
thank you.
That's how we combat stigma, is being able to hear from people like yourself, although I know that can be hard to share, right? To put that out there. So
I'm always happy to, and just being able to advocate for my needs is important. I know we're getting to a point where I'm not going to have to go into the emergency room holding a reserve, knowing I'm going to have to advocate, not knowing what I'm going to encounter. It's been a lot more open minds, and that's all I can really ask for in any of it, is just an open mind. And I appreciate you guys so much for listening.
Wonderful. Thanks, Sabrina. All right.
Thank you.
I see there's some questions coming into the chat, which we'll be very excited to discuss after we hear from Marie-Joëlle. So I'll turn it to you.
Thank you, Katie. It's a real pleasure to be here today with you and to hear the other speakers too. So today I'm going to talk about the tools that we developed in Saint-Justine for sickle cell disease, for the sickle cell disease population. Maybe I could, next slide, please. Maybe I could just explain a little bit what is sickle cell disease for those people who are less aware of this entity. So it's a genetic disorder, which in Canada affects about 6,000 Canadians. And what happens is that you can see, as you can see on the picture, the red blood cells are sickle-shaped due to the genetic mutation. And what happens is that this shape of the red blood cell, which is abnormal, tends to obstruct the blood vessels. And so it blocks the blood flow and it leads to several complications. And one of the complications is called vaso-occlusive crisis. And this leads to acute and severe episodes of pain. Next slide. So these acute pain episodes are a clinical hallmark of sickle cell disease. And often children and adults who have an acute pain episode need to come to the hospital for pain management. And the pain management is often done with IV or oral opioids, among other medications that are also used. Managing sickle cell disease pain is sometimes really difficult and complex. And so we see also that it has major impacts on health-related quality of life for patients. For example, some studies have shown that a lot of the adolescents and children with sickle cell disease were missing several days of school every year. And what we know also more and more is that children and adults with sickle cell disease have these acute pain episodes, but they also have to live with non-crisis pain and chronic pain much more than we thought initially. And so it's another burden for people living with sickle cell disease. Next slide. As you can see in this study that was published a few years ago, they looked at daily assessment of pain in adults with sickle cell disease. And what they saw is that the patients had to fill up a daily diary for up to 6 months. And we could see that 3.5% of the days, the people were having an acute pain crisis that needed medical consultation. But then other than these consultation, we could see that adults were living with pain on several days without necessarily having to consult a doctor or going to the emergency department. So about 30% of patients reported pain in over 95% of diary days, and more than half of patients reported pain on more than half diary days. So it looks like pain in adults with sickle cell disease is more the rule rather than the exception. And probably as healthcare professionals, we are underestimating the amount of pain these people have to live with on a daily basis. Definitely opioids are a mainstay of treatment in sickle cell disease. So we need opioid usually to treat acute pain crisis. And we treat these acute pain crises with opioids, but also with other medications to make sure that the treatment is optimal. So we use acetaminophen, we use NSAIDs, and sometimes other medications such as ketamine. But definitely opioids are a mainstay of treatment. And this is true for hospital admissions when they present to hospital with acute pain crisis, but it's also true at home because sometimes they feel like patients can manage their acute pain crisis at home with opioids by mouth. And so they do have prescriptions at home to try to manage their pain. And when it's too severe and too complex to manage, then they come to the emergency department or the hematology clinic. What we see from previous studies is that there is definitely some stigmatization that is present in the sickle cell disease population due to this opioid consumption that is needed to manage the acute pain episodes. And also probably the stigmatization is also related to false racial perceptions because I didn't mention it, but sickle cell disease is a disease that is mostly affecting people originating from the African continent. Sorry, I was looking for my English word, and the Black community mostly. And so we also know from previous studies that clinicians often perceive that patients with sickle cell disease are at increased risk for opioid abuse, misuse, and addiction. So we can see that this is a perception, and it has been seen in different studies in the past. But actually, when we look at other studies that were published, we definitely, what we see is that compared to other chronic conditions in the adult population, there is no increased rates of addiction and opioid overdose rates in the sickle cell disease population. And actually, there was a really nice study that was published 2 weeks ago in JAMA Pediatrics that looked at the pediatric population, sickle cell disease population. And what they concluded is that there was no concerning patterns of long-term or increasing use of opioids that were identified within a 3-year period after their first opioid prescription. So although we see this stigmatization and the false perception for clinicians that there's an increased risk of opioid abuse, misuse, and addiction, in the reality, we don't see any higher rates of overdose and misuse or abuse of opioids in this sickle cell disease population. Next slide. So at St. Justine, we are a group of different doctors and nurses that have been working for several years on protocols and ways to improve pain management for the sickle cell disease population. We have a big cohort in St. Justine with sickle cell disease, so that was something that was important to us. And so when we heard with the SCIP about the SUAP project, we thought that it was a really nice maybe population to work with in order to develop some tools that could be useful for the pain management. So the goals of this project, we had several goals. First, we wanted to educate healthcare professionals about appropriate treatment for acute pain crisis in children with sickle cell disease, making sure that the facts were known and that if there was any misconception or misconception about opioid use, we could correct them. And then we also wanted to educate caregivers and families about ways to treat sickle cell pain. We wanted to educate about non-opioid medications, about opioids. There are a lot of myths that are vehiculated across the population regarding opioids. So it was important to us to make sure that the facts were appropriate and known with the caregivers and the parents of these sickle cell disease patients. And we also wanted to talk about non-pharmacological pain treatments, because more and more we really put the emphasis on the fact that as in any other type of pain, sickle cell pain should be treated, yes, with medication, but also associate these medication to non-pharmacological strategies that make the pain much better well controlled, and also it can give you several tools in your toolbox to treat your pain. Next slide. So in the next few slides, I will go through the tools that we created. They were created in French, then translated to English. So for most of them, you have the English version. So this is the first tool, which is a booklet that was produced for families. Next slide. So you can see a few of the pages, actually the pages that contain the information in the booklet. We do talk about opioids, we talk about non-opioid analgesics also, and we talk about different psychological and physical strategies that can be used in association with the medication when you have an acute pain episode. Next slide. Then we discuss about the side effects that can be seen with the opioids, and also that important information about how to store safely these medication, making sure that other people that are living at home do not have access to this medication, to make sure that we can prevent abuse, not abuse, but usage of these medication, let's say from another children, that could be something really problematic. And then next slide. We do also talk about what is opioid tolerance and opioid dependence, because it is often a question that is coming back to us about these medications. So we wanted to make sure that this was clear. And we also wanted to make sure that people could understand that when opioids are used as they are prescribed, the risk of developing a tolerance or a dependence is low. And as we were saying a bit earlier, we can definitely use opioid in a safe way. And so that's what we wanted to vehiculate as a message. Next slide. So this is the last page of the booklet, which shows the reasons why you should definitely consult immediately if you have, let's say, a severe persistent pain or a fever. So these are some reasons that should make you consult your doctor. Next slide. So this is another tool, a one-pager that you can see both the French and the English version. It's a summary of what is present in the booklet, and it is something that can be, let's say, put on the walls in the hematology clinic, or if you have a pediatric clinic. Usually the sickle cell disease patients are followed up in hematology clinic where there is a cohort and people that are really aware of the ways to treat the acute pain episodes. But as any type of pain or any type of medical problem, sometimes you end up having to consult in an area that is not your usual area. And so we wanted to make sure that these tools would be available across Canada, and that even in medical centers where we don't usually see this kind of medical problem, they could have access to these tools and use them adequately. Next slide. This is an action plan that we created for the patients, and it goes with the complement to the action plan that I'll show you in a few minutes. So maybe next slide. In the action plan, we again discuss about ways to actually how to assess pain properly. So what could be signs of pain in children who are younger when they cannot tell about their pain? You know, what signs could show you or indicate you that they have pain, such as crying, refusing to eat, not playing, things like that. And then for older children who are able to talk about their pain, we wanted to show a little bit what kind of pain treatment could be used depending on the pain severity. And then we also, again, talk about other ways of managing pain other than medication. Next slide. So this is the complement to the action plan that is really related to the kind of medication and the doses of medication for every patient. So depending on the weight of the patient, depending on what is working for this patient, is it, you know, what kind of medication is working for them, we will give the specific dosage and for every medication. This is something that they can bring to their emergency room, or if they go somewhere else having an acute episode of pain and they're not at home, they can bring that, and it's much easier for the medical staff that sees this patient to treat properly the patient. Next slide. And the last tool that was created was actually for, I would say, pediatrician and doctors working in emergency room departments. So it was created following the publication of a position statement from the Canadian Paediatric Society talking about how to manage pain in sickle cell disease. So we made a shorter version that is available through the SCIP website and SWAP website, where we can see as a doctor what are the medications that could be used to treat sickle cell pain episode, acute pain episode, and what are the things that we also should not forget about that. So as I said, it's for some doctors working in different places, maybe more rural areas, this is maybe not a medical entity that is seen often. So having access to these tools can be quite useful when you're not used to treat these patients, especially for children. So in summary, I would say that the goals that we really are trying to reach are to improve the resource accessibility across Canada for families, patients, and doctors too, making sure that we are having a safe opioid usage, and also making sure to try to deconstruct some myths that are really present regarding opioid, which is a good medication when it's when used as indicated. And like it was said earlier, it's important to make sure that people also recognize that.
Thanks so much for this great panel discussion and the information and resources that you shared with everyone. This is my opportunity to get the questions in order while Logan launches another poll, and here they are. Okay. As a pediatric physiotherapist working in the public rehab system, who should I refer my clients for proper pharmaceutical pain management? Is it their pediatrician, their physiatrist, their chronic pain clinic, their family doctor?
Maybe I could answer that.
Perfect. Thanks.
I think I would go first. If they have a pediatrician, I think I would go first to the pediatrician. I have to say, I don't know if you were talking about CRPS. If you were talking about CRPS, it is not necessarily an entity that is treated by a general pediatrician on a regular basis. So some people do feel uncomfortable treating this entity. And so they would refer this patient most likely to a chronic pain clinic, which is a clinic where this patient will have a multidisciplinary plan. So yes, they will talk about medication, but they will also talk about other ways of treating pain. And ideally that would be the best way to treat pain. But I think I would go first to the primary physician, so either the general pediatrician or the family doctor, who might go ask for a consultation in chronic pain clinic.
Christina has clarified it's not CRPS or complex regional pain syndrome that she's talking about. It's more other chronic pain and myopathy.
Yeah, so if it's a chronic pain condition, I would say that most physicians, like family doctors and pediatricians, will end up asking for a consultation in the chronic pain clinic. But I would still go first to this primary doctor. I think it makes more sense, and depending on his level of comfort with the entity, then it will ask or not for a consultation in the chronic pain clinic.
Thank you so much. We have one more question before we close out today. At what age and or cognitive level are opioids used as an option for pain management in children and youth?
So opioid can be used in premature babies, so opioid can be used by any child. As soon as you are born, you can use the opioids. And so there is no age limit for opioids for any children. It's not a question of cognitive development. It's a question of, I would say, pain. And so we use opioid among other medications to treat pain, and depending on other medications that have been used, if they are working or not, and depending on the level of pain and the complexity of the medical situation, we will decide to use opioids or not when we treat pain.
Thank you very much. So that's the end of our time together today. Thank you, Katie, Melissa, Sabrina, and Mary-Joelle for sharing your time and expertise with us. And thank you to our audience members for joining in. We know how busy all of you are right now. We hope you depart with some practical knowledge and helpful resources to bring back to your organization. Coming up in March, Children's Healthcare Canada invites you to join us for an online 3-part Child Health Equity, a system-focused learning series. And this learning series includes the following 3 sessions: delivery, equity in all child health care services, inclusive child health research for equitable outcomes, and evidence-informed policy, advancing health equity for all children. The first one related to healthcare services is on March 7th. Second one on child health research and equity, March 21st, and the evidence-informed policy and child health equity on March 28th. Save the date now for Children's Healthcare Canada's 2024 annual conference, where we're excited to head to St. John's, Newfoundland on the 20th to the 22nd of October. And the conference will be co-hosted by our partners, the Janeway Children's Hospital Foundation. It's always a pleasure to have you online, and it's great if you watch live, as your questions and comments really enrich the discussion. But if you can't, the recordings of these sessions are made available after the fact on our website. Thanks again for joining us today. Thanks to our wonderful speakers for this presentation and the resources they shared, and hopefully we'll see many of you back here soon. Bye, everyone.